Good morning, everyone. I really would like to thank everyone in the audience for their patience and this opportunity to share this video with you during this conference, where I will be discussing the Royal College perspective on interprofessional palliative care education, specifically CBME and the subspecialty medicine program. For the disclosure, I have no conflict of interest for this presentation. The two main objectives would be to briefly discuss competency-based medical education relating to interprofessional education, specifically in subspecialty training, and to introduce the concept behind our longitudinal curriculum titled Tools to Take Anywhere: Comprehensive Care for Patients with Complex Serious Illnesses. Most of us are now familiar with the concepts of competency-based medical education and the Royal College definitions for entrustable professional activities, or EPAs, and milestones as shown here. Given the complex nature of chronic diseases, it is not surprising that subspecialty programs would expect their residents to show competence in providing care for patients with end-stage disease, which is one of the EPAs for GIM as an example, and we see over here the relevant milestones. Similarly, this is an EPA for nephrology fellowship program, expecting residents to show competence in facilitating a patient's transition to an end-stage renal disease treatment modality or to end-of-life care and the milestones associated with it. Although we saw two examples of EPAs for facilitating end-of-life care, the milestones associated with these EPAs are also integrated with other EPAs in the subspecialty fields, especially when taking care of complex, chronically, seriously ill patients. Here are a few of the examples of milestones that form the building blocks of some of the EPAs when providing care for complex, seriously ill patients that show the importance of communication and collaboration in an interprofessional setting. Starting July 2019, some of our subspecialty programs have gone live with CBME. Using MedSys as an interface, all residents are expected to be assessed on their EPAs to show competence in order to successfully graduate from their programs. The format of CBME now provides unique structured opportunities for residents to be assessed by their faculty on EPAs in the interprofessional clinical setting, combining it with narrative evaluations from other professionals. An example of this would be if I have observed my resident discussing the management plan for a patient with the nurse and the patient themselves, including discussing goals of care, and I would complete their EP assessment with a narrative evaluation from the nurse providing feedback. These medical competencies, especially those related to taking care of complex, seriously ill patients, cannot be limited just to a palliative care rotation and need to be integrated into the daily interprofessional clinical context that the resident is working in and will be practicing in. This is where we hope that a longitudinal curriculum can equip both faculty and residents with tools that they can use when managing complex, seriously ill patients in their daily interprofessional clinical settings, and provide a scaffolding for experiential learning and reflective practice, and allow these EP assessments to take place for the learner. The pilot phase of this two-year longitudinal curriculum was piloted in collaboration with nephrology in 2017, with the second phase starting with nephrology in July 2019. And our hope is that with the third phase, we would be collaborating with other subspecialties such as critical care, GIM, respirology, emergency medicine, and palliative care. The full credit of developing this longitudinal curriculum goes to these three experts and my personal heroes, Ann Woods, Kathleen Wilson, and Ann Boyle. I've had the privilege of working with these three in facilitating and revising the educational design for the curriculum. The core planning team, on an ongoing basis, has taken input from subspecialty program directors, faculty, and resident representatives to contribute towards the curriculum development and mapping to provide an effective and engaging experience for the subspecialty faculty and residents participating in the workshops, and we plan to continue doing so. A variety of teaching modalities have been incorporated to provide for a diverse and engaging experience and to engage interprofessional education, which has included and not limited to flipped classrooms, small and large group discussions, experiential learning and reflection, and simulation. 12 workshops covering various topics as outlined are conducted over a period of 2 years, every 2 months, for a period of 2.5 hours, and are facilitated by a diverse group of faculty, including physicians, nurses, social workers, and other professionals. For more direct observation in a safe learning environment, the residents engage in a simulation-based interprofessional education sessions where they are assessed on the medical competencies related to taking care of complex, seriously ill patients. They can then practice these skills in their clinical settings, which could include an outpatient setting, and can get assessments in either the form of EPA assessments from their faculty or narrative evaluations from allied health professionals that they work with. The residents similarly can identify opportunities during their inpatient clinical rotations to be assessed in an interprofessional working environment, and also use these cases to engage in a reflective practice during their workshops. To evaluate the effectiveness of the pilot phase of the curriculum when it was run in the nephrology program, we looked at learner satisfaction, formative assessments of the residents, feedback from patients and nursing staff where possible to directly observe the residents, and also the number of consults to the palliative care from the nephrology service. Learning from this feedback, we are continuously revising our curriculum to provide a more engaging experience for our participants, and now plan to include residents and faculty from other subspecialties to add different perspectives to discussions and understand the different roles we can play in collaborative patient care for the complex, seriously ill patient. So the main take-home messages would be how EPAs have provided an organized opportunity for assessment and coaching of palliative care at the bedside in an interprofessional setting, and a longitudinal curriculum such as what we described today can allow holistic development of experiential learning and reflective practice for the subspecialty fellows in their interprofessional clinical settings. Thank you for your patience for watching and listening to this video, and I hope that it was useful. And if there are any questions, please do not hesitate to email me at the email address provided here.